Welcome to the deep dive. We take stacks of information, pull out those key nuggets, and basically get you well informed fast. Today, we're diving into a really important chapter from Varkarolis's Foundations of Psychiatric Mental Health Nursing, 8th edition. It's a tough one.
Yeah.
Sexual assault.
Yeah, absolutely. And our goal today is really to equip you, our nursing students, current and future, with a solid grasp of the psychiatric nursing side of sexual assault.
Okay.
So we'll hit on assessment, therapeutic communication, interventions, basically what you need for clinical practice and, for the NCLEX too.
It's such a vital topic, and honestly, the statistics are just staggering. Did you know something like 19.3% of women and 1.7% of men in the U.S. report being raped?
And that's just reported rape. We know it's often way underreported.
Exactly. So this deep dive isn't just about facts and figures. It's about understanding how you, as nurses, provide compassionate, holistic care in just about the worst situation imaginable. Okay, let's get into it.
Let's do it.
So, first things first, let's clear up some terms. Sexual assault, sexual violence. What exactly do these encompass?
Good starting point. They're broad terms, definitely.
Yeah.
Sexual assault covers, well, a whole range. Unwanted advances, harassment, stranger rape, marital rape, date rape, drug-facilitated assault,
Okay.
and also things like incest, human trafficking, female genital mutilation. And it's not just men assaulting women, right? It's any gender combination, any age. Vulnerable folks like the disabled, the elderly, they're often targets too.
And sexual violence, is that even broader?
Yeah, it kind of takes it a step further. It includes denying emergency contraception or SPI prevention after an assault, organized rape and conflicts, sexual homicide, stuff like that.
So way beyond just rape. And I know the FBI, they updated their definition of rape not too long ago.
They did back in 2016.
Yeah.
And it was a really important change. The definition now is penetration, no matter how slight, of the vagina or anus with any body part or object, or oral penetration by a sex organ of another person without the consent of the victim.
Okay, so what's the key takeaway there for nurses?
The big thing is it now clearly includes crimes against men. It covers situations where there were threats, not just physical force, and importantly, cases where the victim couldn't consent, like a child or someone incapacitated.
Right.
They actually removed the word forcible because, well, rape inherently means there wasn't consent. Force is implied.
That makes sense. Consent is the absolute key. Can you give us some examples of what this newer definition covers, like real-world scenarios?
Sure. The FBI gives examples like, okay, a high school student is given a pill, doesn't remember anything, but penetration occurred. That's covered.
Right.
Or a man with a severe mental disability who can't legally consent. Or maybe a husband penetrates his intoxicated wife with an object. She's too scared to resist. Those all fall under the definition now.
And attempted rape, what's the distinction there?
Attempted rape is about the intent and the action taken, even if it wasn't completed. So maybe someone attacks a woman, tries to rape her, but gets scared off. Or someone slips GHB into a date's drink intending to rape them, but they don't manage to get the person alone before the drug fully kicks in or wears off.
Yeah.
That's attempted.
Speaking of GHB, those date rape drugs, this seems critically important for nurses to know about. What are the main ones?
Absolutely crucial, because they're insidious. The text highlights 3 main ones, and the key for you isn't just memorizing names, but recognizing the effects.
Okay.
So first, GHB, gamma-hydroxybutyric acid. Can be liquid, powder, pill. Sometimes tastes salty. The big thing, rapid onset, like 5-20 minutes.
Wow, fast.
Yeah. Causes relaxation, euphoria, but crucially, disinhibition, deep sedation, and amnesia.
Yeah.
That's the dangerous part. Someone might just look really drunk.
Right.
And overdose is serious respiratory depression, seizures, coma.
Okay, what else?
Then there's rohypnol, or flunitrazepam. Not legal here. It's a pill. Dissolves easily. About 10 times stronger than Valium.
Okay.
Onset again pretty quick, 10-30 minutes. Causes sedation, muscle relaxation, amnesia. Again, looks a lot like heavy intoxication.
And the third?
Ketamine, an anesthetic, liquid or powder. If it's IDZ onset, it's like 30 seconds. Orally, maybe 20 minutes. But the duration is shorter, maybe 30-60 minutes.
But the effects?
A dreamlike state, deep amnesia, and complete compliance.
Yeah.
And that amnesia can last longer than the main effects.
So the common thread seems to be a rapid incapacitation, looking drunk, and memory loss.
Exactly. That amnesia is huge. It makes reporting, investigating, everything so much harder. And for you as nurses, this is why screening is vital.
Right.
There's actually the Drug-Induced Rape Prevention Act from '96. Stiff penalties for using these drugs in a crime. You might be the first person to suspect it, so knowing these signs is key. Don't just assume alcohol.
Okay, super important heads up there. Let's shift to prevalence again. You gave the overall numbers, but who are the victims? And maybe more surprisingly, who are the perpetrators?
Yeah, the data really turns some common ideas on their head. We know the overall rates, 19.3% women, 1.7% men. But for women, almost 80% experience their first rape before age 25, 40% before 18.
That young.
Yeah, and both men and women are most often raped by men. But here's the kicker, the part that surprises people. It's usually not a stranger.
That feels like a really critical point. The whole stranger danger thing isn't the main story here.
Not at all. For women, almost half are raped by an acquaintance, about 45% by an intimate partner.
Wow.
For men, 45% by an acquaintance, almost 30% by intimate partners. So the person doing the harm is often someone known, trusted.
Which must make reporting even harder.
Immensely harder. That plus the shame, the stigma, especially for male survivors. It all contributes to underreporting. And it means, for you, building trust might look different if the survivor knows the person who assaulted them.
Makes sense. What else does the data show?
Well, stalking is also prevalent. About 15% of women, 6% of men, mostly before age 25. And race and ethnicity play a role too. Multiracial women report the highest rates, followed by American, Indian, Alaskan, Native, and Black, non-Hispanic women. So it's a diverse picture, often hidden.
Okay. So beyond the physical side, let's talk psychological impact. What are nurses likely to see, especially right after an assault?
This is where your psychiatric nursing knowledge really comes in. Many survivors will show symptoms fitting acute stress disorder, ASD, or later PTSD. But rather than just listing symptoms, think about the patterns you'll see.
Okay, what kind of patterns?
Well, for acute stress disorder, this is usually right after, lasting 3 days to maybe a month, you'll see clusters of symptoms.
Like what?
Like intrusive symptoms, flashbacks, nightmares, the event just forcing its way back into their thoughts. Then negative mood, maybe distorted self-blame, feeling detached, losing interest in things.
Self-blame seems common.
Very. Also, dissociative symptoms. This is a big one. Feeling unreal, detached from their body, this depersonalization or like the world around them isn't real derealization. They might seem oddly calm or numb.
Interesting. Okay, what else?
Avoidance. Trying to avoid anything that reminds them of the trauma, feeling emotionally numb. And arousal symptoms. Jumpy, can't concentrate, can't sleep, maybe angry outbursts. And if these symptoms stick around for more than a month, then we start thinking about PTSD. The symptoms are similar, but persistent.
What about the longer-term psychological effects?
Long-term, you often see depression, anxiety, fear, trouble functioning day-to-day, low self-esteem, sexual problems, and even physical complaints, somatic symptoms like chronic pain or stomach issues that don't have a clear medical cause.
Right.
For incest survivors specifically, you might see more issues with self-image, eating disorders, personality disorders, self-harm, substance abuse. And in psychiatric patients generally, a history of sexual abuse is strongly linked to, well, a whole host of issues. Depression, anxiety, addiction, suicide attempts, self-mutilation, even psychosis-like symptoms.
That's a heavy list. So, given all that complexity, how can nurses best support these individuals?
This is where specialized services are just invaluable.
Like sounds.
Exactly. Sexual assault nurse examiners. These are RNs with specialized training. They do the medical and forensic exams, but they're also trained to testify in court as expert witnesses.
Okay.
They're usually part of a SART, a sexual assault response team. That's multidisciplinary, nurses, doctors, lawyers, social workers, advocates, mental health folks, all working together.
And what's the philosophy behind how they approach these exams?
Patient-centered care is everything.
Yeah.
The DOJ protocol emphasizes prioritizing these patients. Absolute privacy, culturally sensitive care, letting support people be present, using language the patient understands, finding out what their priorities are right now, and smoothly combining medical care with evidence collection.
And timing is critical.
Absolutely. For the patient's psychological state and for preserving evidence, it needs to happen promptly but sensitively.
Okay, this brings us right to the core, the nursing process.
Yeah.
Assessment, diagnosis, planning, implementation, evaluation. How do you apply this in such a delicate situation?
This is really where you put it all together. It's the foundation of your care.
Let's start with assessment. What are the key things, beyond the obvious physical check, that a nurse needs to assess right away?
First off, their level of anxiety. If they're in severe panic, they can't process anything. So your first job might just be helping them feel a bit calmer, safer.
Okay.
Then look at their coping mechanisms. What are they doing? Crying, withdrawing, blaming themselves. Also, figure out their support systems. Who do they have? And remember, even family might not react helpfully.
Right.
And you're assessing for emotional trauma. Is this potentially a legal case, a forensic patient, and obviously physical trauma?
How do you handle the communication piece during assessment? It must be so difficult.
It requires real skill. Only ask what you need for immediate care. Let them talk at their own pace. And the big one, no why questions. Why were you there? Why didn't you scream? None of that. It's not like blaming.
So what do you ask?
Use open-ended, non-judgmental questions. What are you thinking and feeling right now? Tell me what happened, in your own words. What's helped you cope before when things felt overwhelming?
And suicide risk, given the trauma.
Have to assess.
That's rough.
Directly. Are you thinking of harming yourself? Have you thought about suicide since this happened? If the answer is yes, or even maybe, you do a full suicide assessment immediately. Plan means intent.
Okay. Then there's the physical assessment and evidence collection. Balancing medical needs with psychological trauma.
How? You do it together. Provide constant psychological support while you meticulously collect evidence. Explain everything. Check for injuries. Document everything: size, color, location. Use body maps, photos, if policy allows.
And remember, no visible injury doesn't mean nothing happened.
Absolutely critical point. Many assaults leave no visible marks. Then you collect the samples for the kit: blood, hair, swabs. Carefully, chain of custody is vital.
You mentioned re-victimization earlier. Can you explain that again in the context of the exam?
Yeah, it's such an important concept. The physical exam, especially the genital exam, can feel like another violation, another assault. That's re-victimization.
So how do you minimize that?
Constant explanation. Reassurance. Getting explicit informed consent for each part of the exam, reminding them they can say no to any part. Offering prophylactic meds for STIs, HIV, pregnancy explaining emergency contraception, prevents ovulation. It's not an abortion pill, assuming they weren't pregnant before.
What about the nurse's own feelings? Self-assessment.
Crucial. Your own biases, your own history, your beliefs about rape myths, they will affect your care if you're not aware.
Like the example in the text, the nurse who didn't believe the calm patient.
Exactly. Because the nurse hadn't examined her own beliefs about how a real victim should act. People react in vastly different ways. Calmness, even smiling, can be a shock response. You have to check your own baggage before you walk into that room. Okay, moving on to B, diagnosis. What's the main one here?
The most specific is rape trauma syndrome. It's defined as a sustained and maladaptive response to a forced, violent sexual penetration.
And the signs?
Shame, guilt, helplessness, anxiety, fear, mood swings, sleep problems, nightmares, sexual issues, even suicide attempts. You might also use diagnoses like disturbed personal identity, situational low self-esteem, anxiety.
Makes sense. And for C, outcomes identification. What are we aiming for?
Long-term, the goal is pretty much the absence of any residual symptoms. Signs of improvement include things like the survivor expressing they had the right to be safe, physical healing, expressing anger healthily, feeling empowered, feeling hopeful, having comfortable relationships again.
Okay. And D, planning. What's key there?
Follow-up. The plan must include clear steps for follow-up care and links to community resources. This isn't just an ER visit. The effects last.
Right. Now, E, implementation. Putting the plan into action. Let's use that case study, Kayla. 36. Raped after accepting a ride. She keeps saying, I shouldn't let him take me home. I should have thought harder. How does the nurse intervene?
That self-blame is so common. The nurse needs to gently redirect. Maybe start with validation. Kayla, you've been through something terrible.
Okay. And when Kayla says, I feel so ashamed. I shouldn't have let him take me home.
The nurse might use reflection. It sounds like you're feeling responsible, like if you hadn't taken the ride, this wouldn't have happened. You acknowledge the feeling without agreeing with the blame.
And if Kayla persists, I shouldn't have let him rape me.
Then the nurse might gently bring in the reality of the threat.
Kayla, you mentioned he threatened to break your neck if you didn't comply.
Reminding her of the danger.
Exactly. Then maybe follow with something like, it sounds like you did what you had to do to survive. Staying alive was the priority. Shifting the focus from blame to survival to strength.
That's powerful. So beyond that conversation, what are the concrete actions for Kayla or any survivor?
Okay, the checklist includes: get a support person if possible. Explain the whole legal rape protocol process. Get consent step by step. Document everything meticulously: mental state, physical state, injuries using body maps. Collect the evidence kit samples. Provide crisis intervention counseling right then.
Offer the prophylactic meds for pregnancy and STIs. Explain HIV testing. Give written instructions for everything: meds, follow-up, crisis lines, legal aid. Anxiety makes remembering verbal info really hard.
Good point. Written instructions are key.
Refer them to advocacy programs. Encourage talking, but don't push. And educate them about common reactions down the road: flashbacks, sleep issues, anxiety triggers, so they know it's part of the process, not them going crazy.
And follow-up is crucial for self-care and case management, right?
Absolutely. Those follow-up visits at 2, 4, 6 weeks are vital. Check psychological status, screen for STDs, check pregnancy status, and keep addressing the stigma around getting mental health help.
What about advanced practice nurses? What's their role?
Psychiatric NPs, or clinical nurse specialists, can provide ongoing therapy, individual or group. Group therapy can be really helpful for building coping skills. They treat the PTSD, depression, any other psychiatric issues that arise. They might also work with perpetrators, although that's challenging if the person doesn't admit they need to change.
Okay, finally, F, evaluation. How do we know recovery is happening?
We look for signs like sleeping okay, eating normally, feeling relatively calm, maybe still some appropriate fear but not constant panic, using their support system, feeling okay about themselves, fewer physical complaints, and eventually returning to their previous level of sexual functioning and interest, if that's right for them. Basically, the closer they get back to their pre-assault life pattern, the more complete the recovery.
Wow. Okay, this deep dive really underscores how complex and incredibly important this area of nursing is. It's so much more than just physical care.
It really is. And what strikes me is how every part of that nursing process we just walked through, the assessment, the communication, the interventions, the follow-up, it all has to work together to truly support and empower the survivor. This is real-world nursing making a huge difference.
Yeah, it connects directly to that idea of holistic, patient-centered care. Thinking about ethics, cultural sensitivity, being an advocate, it's all in there. And for you listening, it means your empathy, combined with this knowledge, is probably your most powerful tool. Absolutely. Remember, your role goes way beyond just the tasks. You're an advocate, a careful evidence gatherer, a link to help. Understanding the trauma and responding with skill and sensitivity, that's paramount.
So as you keep going in your nursing journey, just know that building this knowledge, especially in mental health, isn't just about passing exams. It's about building your capacity for real human connection and empathy.
Well said. Thank you for joining us for this deep dive. Keep learning, keep growing that empathy. You really are shaping the future of healthcare.
From everyone here at the Last Minute Lecture team, thanks for tuning in. Until next time, keep digging deep.